So I've got this, you know what? No, you've probably got this. You've got one of those patients, you've got this patient who happens to have something called a disc herniation or a disc bulge. And you're going to have a lot of these because it's a pretty common thing. And it's usually L4, L5, S1, somewhere within that region. So what we've got is a disc in between the vertebra and intervertebral disc. And it's got an outside annulus fibrosis and an inside nucleus pulposus. And when it bulges or herniates, if it's bad enough, if it's in the proper direction, and if there's inflammation they're finding, that's another key finding here. If there's inflammation because of the tear or the bulging, it will move backwards, and then it will hit on one of the nerves in the area. If it's a 4 or a 5, that's an easy one. This will be internal, of course, I'm drawing it external. It will hit on a branch of the sciatic nerve, a root to what will become the sciatic nerve, and S1 easily can do the same thing. There's a lot of nerves going through here, so it's very easy to reproduce this. So those disc herniations, those disc bulges, can cause some serious pain and problems. Now, looking at the disc herniation, you would think this would take a tremendous amount of force, and certainly it does. It could be a sudden moment of impact that creates this disc herniation, a sudden impact force like a car accident or lifting too much weight or having something dropped on you suddenly. That can certainly do it. That's a traumatic cause. But there's a lot of disc herniations and bulges that are non-traumatic in origin. They are idiopathic. You need a doctor to diagnose these things, preferably a radiologist with a CT or MRI in hand, and that's your best bet for actually figuring this out. But the cause is not explained in these CTs or MRIs. Let's theorize a couple things, and we can only say theorize because of legal reasons. So, looking at a disc herniation, let's go to a simplified model here. Looking at a disc herniation, this would be our normal lumbar spine here. If we have nice, smooth motions, everything's relatively straight, things seem to be okay. In fact, in the lumbar spine, it would be a little bit more of a curve. Anteriorly, we call that an extension curve. In a disc herniation, what you'll notice is we don't have a nice smooth curve. What we have is a forward flexion. If we're looking at this lumbar spine, there's the spinous processes off the back, and then we of course have our spinal nerves coming off that with our nerve roots coming off there. So there is a flexion, something has bent forward. Now we could theorize that because we've compressed the disc, we've lost height, it drops forward into flexion. But that flexion is kind of the perfect thing to create that. And it means that something is essentially pressing on the front. The weight, heck of a lot of weight, over a heck of a lot of time, is probably compressing it. So let's think about that. We could have it so it's very much a possibility that the pelvis has gone up and it's compressing from the bottom up. So it's gone like that, potentially, again, theoretically. It's gone like that, and now we have weight being borne this way. That's the wrong tool. That way. There we go. That'll do. Layer on layer, eh? So it's going from the bottom up. Now, we could easily say that that's probably not the case, because if this were a fact, it would mean everybody's hips would have to be in hyperextension simply to walk appropriately, and we'd have a whole lot of hip pain really on the front, and we'd have all kinds of strained knees, and it just doesn't seem to be the case for the most part. And you can test whether hips like that. What we usually find, getting rid of a few of these things first, what we usually will find is that it is flexed in the lumbar area at about L4, L5. So we've got this type of a curve here. Let me make that touch bigger. There we go. Flexed here. Too big now. Too small, too big, too small. There we go. Flexed here. And then hyperextends very quickly in the L5-S1 junction. Then goes back into a hyperextension. Very, very extended, we can easily say, at about L2, L3 on 4, and then back to a flexion here. Now this is where it gets interesting. So curve on curve on curve. Let me throw in one more just to make it nice and smooth. So in the lower thoracic flexion, upper lumbar extension, flexion again, followed by extension. That kind of a curve seems to be the case. So when we have this, notice what will happen to the thorax. Cleaning this up one more time. There we go. Flexion, extension. One more time, one more time. We can do better. We can always do better. There we go. So when we have this flexion in the curve, that's being pushed back, essentially. This will force the thorax to flex down just a little bit. Doesn't have to be a lot. Just a little bit will do. That's all it takes. When we drop that thorax forward, the head has to go with it. It has to come forward. It has to come into a little bit of extension as well. And so this changes the way the body is bearing weight. This changes what is going on in an important way, one that should be recognized. So let's talk about this. As the head comes forward, and this can be a lot of conditions, but as that head comes forward, center of gravity, the body weight, is dropped more anteriorly. It's dropped forward. And that's an important thing because as we drop the weight forward, because of this flexion right here, which is so common in people who have lower disc herniations, L4, L5S1, because of this flexion right there, it puts the pressure now of the body anterior. It's a bit off the spine, or at the very least, it's not evenly balanced between the front and the back of the vertebrae. So going back here, we've got it loading through here. Some weight should be borne through the posterior column of the spine. Those facet joints, believe it or not, are solid, compact bone and have the ability to take on some weight. So now we've shifted it more so to the vertebral body and disc all the time, every step, every little bounce you make. And so even though it's coming from here, it's going to put a lot more weight on these vertebrae in front here. It's going to put a lot more weight right, layer, right there, right on that curve, on that L5, S1 area. And it creates quite a bit of a pinch point. And now, if it just so happens that that one spot is essentially localizing all the weight of the body, all the weight of that upper body is coming there. Every movement forward, back, left, and right is now focused on that L4, L5, S1 region. And that's a lot of weight that it wouldn't normally have to bear. It's a lot of weight for something like that to have to take on. So it's very understandable that when there is a disc problem, the disc might herniate, the disc might come out of place due to a tearing of ligament or a bulging and expansion of that ligament. These are very reasonable things to assume. And again, this is a theory. No need to lose your mind. So let's talk about why this can be sustained, though, because there's one thing to cause it. This is one thing to just say this stuff, but let's talk about why. Because what we have is a short front. The front of our body has come down and forward. It's come like this. So what in the front is holding it? And we can have a few examples here. We've shown them. These pictures are all from the app, by the way. You've got, just in this diagram here, you've got a SCM, sternocleidomastoid mastoid muscle. There's your origin, and there is your insertion, of course. Now, any muscle can pull in multiple directions. That's just how they're made. You shorten a muscle, it will pull from one side to another. So if this muscle was short and we were allowed to fall forward, it would start to pull the head anterior, just like we have here, like that. That's very, very possible. We also have a pec minor muscle in this case. And though we have an origin on the ribs and insertion into the coracoid process, it could also work in reverse. And when it pulls short, it will take the whole shoulder and clavicle with it into a protracted position. And that is very much the situation we'd have in a thorax that is dropped forward. Protraction. That's the pec minor. Now we could say the same thing of the pec major too, because it occupies this space, but let's not complicate things. Rectus abdominis is another really good one because of the fact that it goes from xiphoid process all the way down to the pubic symphysis. If it were to shorten, we would get a shortening along this line, and that is the thorax dropping down towards the pelvis. So again, these are reasonable things. Now, it doesn't actually matter whether these muscles are contracting or not. It doesn't mean they have to be constantly acting to do so. If they are put in this place by simply the act of gravity, flexing these things down, flexing and hyperextending these things down, it doesn't matter if they are contracting actively. If they are simply held in a position for a long period of time, months, years, decades, they will start to occupy that space, and it will be impossible for them to right themselves without specifically releasing those muscles. So, over the course of time, as we hold ourselves forward and protracted and down, we start to add more and more of our body weight onto that L4, L5, S1, and it sinks deeper and deeper into that flexion, and the compression of the disc starts to occur. And inevitably, and theoretically, we could see a bulge or a herniation happen that, though it didn't have a single traumatic cause, it could have a long-term, constant pressure cause. This has been Elge for Simple Lines Anatomy. We got all that social media stuff. If you wanted to, we've also got an app. These pictures that I just showed you here, they were in the app initially. Recently, we've found that people get really stressed out by anatomy pictures, so we've basically replaced them all with just cat videos.